Video footage.
Recording in progress.
As we prepare for travel, we recheck details, practice new languages, review destinations.
Do not travel advisory. Recommended that United.
But plans never keep up with changes. So, until the day we meet again, we will keep preparing. Preparing to welcome you on your wonderful arrival. Welcome to Taiwan. As we prepare for travel, we recheck details, practice new languages, review destinations.
Do not travel advisory. Recommended that United.
But plans never keep up with changes. So, until the day we meet again, we will keep preparing. Preparing to welcome you on your wonderful arrival. Welcome to Taiwan. As we prepare for travel, we recheck details, practice new languages, review destinations.
Do not travel advisory. Recommended that United
But plans never keep up with changes. So, until the day we meet again, we will keep preparing. Preparing to welcome you on your wonderful arrival. Welcome to Taiwan. As we prepare for travel, we recheck details, practice new languages, review destinations.
Do not travel advisory. Recommended that United
But plans never keep up with changes. So, until the day we meet again, we will keep preparing. Preparing to welcome you on your wonderful arrival. Welcome to Taiwan.
Very good evening to all. Namaste.
As we prepare for travel, we recheck details, practice new languages, review destinations.
Do not travel advisory. Recommended that United
But plans never keep up with changes. So, until the day we meet again, we will keep preparing. Preparing to welcome you on your wonderful arrival. Welcome to Taiwan.
Record.
As we prepare for travel, we recheck details, practice new languages, review destinations.
Do not travel advisory. Recommended that United
But plans never keep up with changes. So, until the day we meet again, we will keep preparing. Preparing to welcome you on your wonderful arrival. Welcome to Taiwan. As we prepare for travel, we recheck details, practice new languages, review destinations.
Do not travel advisory. Recommended that United
But plans never keep up with changes. So, until the day we meet again, we will keep preparing. Preparing to welcome you on your wonderful arrival. Welcome to Taiwan.
Hi, everyone from Asia and all over the world. This is CPD Asia, the online continuing professional development platform for Asian Radiologic Technologist societies. And hosting the 22nd CPD Asia is the Taiwan Association of Medical Radiation Technologists, TAMRT. And I am Peachy Luna, your program host. We are again grateful to our many sponsors, including the VT Healthcare Vietnam, in helping us organize the online CPD Asia. And we are live streaming on YouTube. Please search PARI and VART so you can join us live or watch a replay using the PARI and VART YouTube channels. This CPD Asia is highly supported and graced by many member society presidents, the officers and representatives. Let us greet and welcome President of Macau Radiological Technologist Association, MRTA, President Fernando Kok.
Hi, good evening, everyone. I want to for this opportunity to introduce my society new chairman, Cora. Cora, say hello for.
Hello, everybody.
On the last week.
Hello.
Thank you.
Thank you, President Kok, and welcome, Ma'am Cora now. Let's greet now President of Perhimpunan Radiographer Indonesia, Indonesian Society of Radiographers, or PARI, Dr. Giek Sugianto.
Hello, hi everybody. Good evening, all of you.
We also have our President of
Hello.
Vietnam, Association of Radiological Technologists, VART, President TAIWAN Loc.
Yeah, good evening, everybody. Good evening, everybody. Hi.
Yes, and we have the President of Hong Kong Radiographers Association, HKRA, President Won Shin Boon Nelson.
Hello, everyone.
And attending for Singapore Society of Radiographers, SSR, for President Dennis Chu, attending is the SSR officer, Ms. Joyce Tan.
Hello. Good evening.
Next, we have our President of Malaysian Society of Radiographers, MSR, President Sawal Marsait.
Hello, hi. Good evening, everyone. Hello.
Yes, and we also have President Selva Kumar of the Indian Society of Radiographers and Technologists, ISRT.
Namaste, welcome to you all. Very good evening.
We also would like to greet presidents from our participating societies, President Mohammed Al-Bagani, Vice President of the Palestinian Association of Medical Radiation Technologists, PAMRT. We greet President Sophie Lee of the Association of Cambodian Radiological Technologists and President of the Philippine Association of Radiologic Technologists. And we have also our members from Myanmar Society of Medical Radiation Technologists. So now also attending with us our invited panelists from different countries, and we will be introducing them later as they join also our presidents attending as panelists. So I would like to humbly request our dear presidents, all the speakers and our moderator to please open your camera for a short photo session. All right, thank you everyone. So now to formally start the program, please welcome the President of Taiwan Association of Medical Radiation Technologists, TAMRT, President Chun Yuan-tu, to give us an opening speech and his welcome message.
Good evening, President and participants. Thank you for taking time out of your busy schedule to attend the 22nd CPD course. On behalf of TMRT, I'm extremely delighted to be here and address you all. Before we carry on with the course, I would give my appreciation to all the invited speakers who made this occasion a reality. I'm sure the course will be profitable and fruitful for everyone present here. Thank you.
Well, thank you very much. There you have the President of Taiwan Association of Medical Radiation Technologists, President Chun Yuan-tu. So to begin the interesting program, allow me to briefly introduce our program moderator, Ms. Alice Chang. Alice Chang has graduated from the University of Sydney, Master of Diagnostic Radiography. Our moderator is the Vice Chairman of the International Affairs Committee from Taiwan Association of Medical Radiation Technologists. Let's all welcome Alice Chang.
Hello, everyone. Good evening, and I'm Alice. I'm the Vice Chairman of the International Affairs Committee from Taiwan. And so today we have three outstanding speakers in today's online meeting. So let's welcome to our first speaker, Mr. Yu Changqing. He currently serves as a radiographer at the Department of Nuclear Medicine in Kaohsiung Veteran General Hospital. He's going to talk about the feature description of identification of TC99M MDP whole body bone scan meta-test images by computer-aided diagnosis system.
Hello everyone, nice to meet you. My name is Yu Changqing. I'm come from the Department of Nuclear Medicine Kaohsiung Veterans General Hospital in Taiwan. And today I would like to talk about the visual description of identification of TC99 MTP whole body bone scan metastasis images by computer-aided diagnostic system. And first, this is my content. First, I would like to talk about what is the whole body bone scan. We call the WBBS. The skeletal is one of the most common sites of the distant metastasis in many cancers, especially in breast, prostate, and lung cancers, which are known for their high incidence rate of bone metastasis. Indications for bone scintigraphy (BS) include benign and malignant diseases, infections, degenerative changes. However, the poor spatial resolution of planar scintigraphy. And this is our typical bone scan image. At first, we would like to talk about the IV have the hotspot and the urine in the bone image have the show hotspot too. But another case is the osteonecrosis in our hip joint here will show the cold spot because this area, the blood cannot into the hip joint here. So here will show the cold spot. And the urine will very hot spot over in our bladder here. And in this case, we will look at the hot spot on our rib here, but we cannot make sure it is a true trauma or DJD or metastasis. This is our confused in our bone scan image. And BS high is high sensitivity and cheap, especially single photo initial computer tomography, we call the SPECT-CT, has been shown to be a useful investigation in the lesions equivocal on bone scan. Due to limitations in diagnostic methods, clear evaluation of lesions within the skeletal system still remains a clinical issues. And we will talk about my motivation and purpose. We developed a CAD scheme termed irregular flow viewer. We call the IFB based on gradient vector flow and examine our patient to improve the limitation of BS. We aim at how to increase the visual quality to identify the correlation between the WBS by IFB magnetic response image, we call the MRTA, or computer tomography, we call CT for bone metastasis. And then we will talk about the relative works. We will use the gradient vector flow, we call the GVF. Medical image segmentation used in medical applications that include quantitative clinical tools for elevating bone metastasis. And von Itro demonstrated a gradient vector flow GVF detecting model and described a quantitative scheme to detect possible abnormalities. And computer-aided detection, we call the CAD system. Wang et al. Described a computer-aided automatic lesion detection system that is useful and can be used to identify possible bone lesions. We try to develop an artificial neural network interface by the gradient vector flow (GVF) scheme to assist for the characteristic index of the blood flow dynamic index analysis. And a self-organization map, we call the SOM, or self-organization future map, SOFM, is a type of artificial neural network ANN that is training using unsupervised learning to produce a lower dimensional discretized representation of the input space of the training samples called a map. Like most artificial neural networks, SOMs operate in two modes, training and mapping. And this is our flow chart for the purpose scheme, search for hard point. At first, we input the DICOM image. Patient, we separate 4 types. One is normal, second is DJT, and third is mild, and fourth is severe patient. And then next step is into the AN resource or IFB interface. And in this phase, we will get the gradient index for 2 index scalar index. And then IFB, we will get 10 index with the self set or union set. And then we will to use the statistic average. Then we got the ACVPS. And part 2, we will determine the status of the patient by the abstract distance to the ACVPS. And to use the RC plot show the efficiency of the central methods. And determine the status of the patient by SON, AN, and methods. RC plot show the efficiency of the central methods too. And now we would like to talk about the third materials and methods. At first, figure 4 shows the overview of the components of the gamma camera. Gamma camera is very important in our nuclear medicine department. At first, the patient have to put inside the isotope, then from their body have the radiation. The scatter will separate from the collimator, and into the another step is the NNI silane crystal, PMT, and finally we will get the image from the pulse height analyzer. And we use the data acquisition and the precision by figure 5 Philips Brightview machine or Siemens Symbiote SPECT CT to acquisition our image. And then we will get 106 post-CA patients from August 2019 to August 2022. At first, we have to put inside 20 millicurie TC99 MDP injection, and after 2 or 4 hours later, scanned by a gamma camera. And urination to empty blood bladder and remove the mental objects before the examination is necessary. And then we will get about 40 normal patients and degenerative 70 patients, and total patient is 57 patients. And 15 patients is mild MRTA, and 34 patients is severe MRTA. And MRTA patients we got total is 49 patients in our prostate cancer. And lung cancer patients from August 2019 to August 2022, also we will get 42 normal, or degenerative is 30 patients. And MRTA has 15 patients, severe is 30. And then 162 patients in breast CA, also from 2019 to 2022 August. And normal is 33, and degenerative is 61. And meta has 33, and severe has 35 patients in the breast CA. And we developed a computer-aided detection scheme we call the Irregular Flaws Viewer, IFB, that we hope that can solve the possible limitations of WBS. This design not only evaluates the irregular flaws in the bone marrow or from planar WBS image by computer-aided detection system, but also provides an algorithm to indicate the distribution of hotspots in the irregular flaps. And then we will talk about the experiments results. In table 1 is showed the prostate about total is 106 patients, and normal is in male patients 57 patients, and meta have the 49 patients in the prostate CA. And we will got the gradient value index, dynamic value index, different value index. Over here we can separate 4 types of the different kind of the index. And figure 6 shows the index grade RC curve of the prostate CA, and here is the index grade SUC equals 89%, and SON AUC equals 82%. And table 2 shows our breast CA total patient is 162, and normal has 94 patients, and meta has 67 patients. And here we also got a different kind of the normal degenerative than mild or severe meta patients. So we can separate 4 types and got different gradient value index or dynamic value index over 4 different kind of the separate disease, or normal have a different kind of value index. And we got the index grades RC curve of breast CA. Index grade AUC is equal 85%, and SOM AUC is equal 63%. And table 3 lung cancer, we have total 100 patients. Normal is 55 patients, and meta have the 45 patients over here. And we also got 4 types of different kind of methods to separate what is the gradient index or dynamic value index over here. And in the lung cancer here, index grade AUC is equal 72%, and SON AUC is 70%. And 5th, we will talk about the performance evaluation. This is a case report 1. A 55-year-old woman with endometrial adenocarcinoma and multiple metastasis status post cytoreproductive surgery 1.5 years ago. TC99 MDP WBS showed bone metastasis to scar. However, either active bone lesion or normal bone metastasis in the T-spine is reported. We can see the figure A. And figure B, the patient complained of the intractable back pain over the left anterior chest, and the MRI performed. The to reveal a tumor mass involved in the left T7 to T9 region. She underwent decompression surgery over T7 to T9 as well as radiotherapy and salvage a vaccine treatment. The biopsy showed metastatic differential carcinoma. Over here we can see the MRI have the different indication over here. And the case report, we show the planar WBS scan is normal on the patient. The T-spine is normal, and B is show the bone static from his scar. From her scar have the little lesion over here, but MRI image showed the T-spine over here has a tumor too. We can comparison with planar WBS and MRI image, but we cannot make sure in our bone scan it is true meta or normal. And case report by IFB result after analysis of the planar WBS by IFB, we found new metastasis lesions in the T7 to T9 region. Over here, there has the more hotspot in our sternum in anterior view. This is the same case, but the bone scan with the posterior view. And the T7 to T9 over here, red arrow, red point. The predicted lesion was similar to the MR data. And this is our bone scan, and this is our IFB with the bone scan post-processing image. Here have the hotspot. We can show the more indication or more different area from the bone scan. So finally we will talk about the conclusion and discussion. In our study, a total 368 patients of the 45.9% of the male patients, 73,159 and 42.100% of female patients, 88,209 had bone metastasis. The sensitivity to predict skeletal metastasis or not was better in prostate cancer 89% than breast cancer 85%, and lung cancer is 72%. Compare the clinical diagnostic reports of the MRI, CT, SPECT CT or PET CT with IFB BS reports. The corresponding results shows the sensitivity to predict skeletal metastasis in prostate cancer is 93%, breast cancer is 91%, and the lung cancer is 82%. And table 5 comparison reports between proposed methods and the other methods. We can get the IFB with the BS MRI CT or PET CT. RC is 2092 in our prostate CA, and 91.4 is breast in our breast cancer, and 83 is in our lung cancer. In conclusion, IFB have increased the accuracy of detection of bone metastasis and thus physicians in the diagnosis. However, this tool still needs more study, design, and data validation. Finally is our future work. In the future, some issues will be addressed. First, to build a database which is suitable for patients in all ages for solving the problem of the limitation for adults only in algorithm. 2. To develop another analysis algorithm to detect the core lesions. Osteolytic lesion. 3. To define another image processing methods to adjust the lesion threshold value. 4. The overall system construct and the evaluation will complete it. Here is my reference. And thank you for your attention.
And I'm going to introduce the next speaker. The next speaker is Mr. Su Maoyuan, who serves as Department of Medical Imaging, National Taiwan University Hospital. His presentation is the role of radiological technologist in cardiovascular magnetic resonance.
Ladies and gentlemen, my name is Maoyuan Su. Today I'm talking about the role of radiological technologist in cardiovascular MR. CMR has been considered as a vital imaging modality in the evaluation and the management of a wide range of cardiovascular disease. CMR can obtain the structure and functional information in one-step exam. We can use cine MRI to measure the cardiac function, use the LG MRI to quantify the myocardial viability, and use the DCE MRI to identify the myocardial perfusion. However, even the CMR plays an important role in cardiovascular care, but its availability still limited and has significant regional variations in different countries. Because competent and well-trained CMR technologists are fundamental key to the success of CMR exam. Therefore, in this talk, I would like to share the knowledge, experiences, and skills required for radiological technologists to be competent in CMR exam. For CMR exam, there are 3 important steps. First one is patient preparation. We need ECG for cardiac gating. We have to teach the patient how to hold their breath and record the body height and body weight for cardiac mass correction. Since the heart is not located in the middle of the body, we need to localize the viewing planes for CMR scanning. After obtaining the localization of the heart, we can acquire image data according to the need of the patient. My talk will be based on 3 steps. For patient preparation of CMR, first of all, we need to make sure the patient is clear and able to cooperate with immobility and breath hold commands during scan. We also have to check if the patient has arrhythmia or any contraindicational devices in the heart. Patient may need clothing change. The patient may need IV for contrast media injection. If patient has critical condition, you may need to prepare the physiological monitor for patient condition monitoring. Once the patient has entered the scanner, we need to localize the viewing plane of the heart before the image acquisition. In general, we always acquire the 3 image planes, such as sagittal view to see the anterior and posterior, coronal view to see the left side and right side, then acquire the axial plane to cover the range of interest Since the heart is not located in the middle of the body, therefore, we need to localize the viewing planes for CMR acquisition. For example, four-chamber view can review the left and right heart. Two-chamber view can see the anterior and posterior. Short axis can use to cover the long axis of the heart. Next, I will introduce to you how to perform the image localization of the CMR. First, we acquire a transfer plane of the chest to see the heart. Then cut a plane which parallel to the ventricular septum to bisect the longest dimension of the left ventricle chamber to get the shoulder two-chamber view. As shown here, why I call it shoulder? Because this image plane may be not perfect and need to correct by following procedures. From the shoulder two-chamber view, we can cut a plane from the mitral valve to the apex to get the shoulder four-chamber view, as shown here. After obtaining the shoulder 4 and shoulder 2 chamber views, we can copy the image position of shoulder 2 chamber view and perpendicular to the septum on the shoulder 4 chamber view to get the shortest view covered from mitral valve to apex. For obtaining the true 4-chamber view, we can use 3 points localization method. The first point is located on the central cavity of the basal level, as shown here is number 1 point. The second point is located on the central cavity of apical level, as shown here is number 2 point. The third point is placed on the corner of RV, as shown here is number 3. These 3 points will rebuild a plane in bisecting the mitral valve to apex, as a line here, and extend to RV to get the true 4-chamber view. From the true 4-chamber view, we can cut a plane from the mitral valve to the apex and parallel this cut plane parallel to the septum in both 4-chamber view and shortest view to get the true 2-chamber view. Once we have 4-chamber view, 2-chamber view, and shortest view, we can use 3-point localization methods again to acquire the 3-chamber view. First point and second point are same as 4-chamber view, located on the central cavity of basal and apical level of the shortest view. The third point is placed on the LT valve to bisect the LV outflow tract to obtain the 3-chamber view. From the 3-chamber view, we can see the LA, LV, and aorta. After obtaining the 3-chamber view, the left aortic outflow tract LVOT is ready to obtain by bisecting the ascending aorta in LT valve on 3-chamber view. For right 2-chamber view, we can move the cut plane. For the left 2-chamber view, as shown here is blue line, then move it to the right side of the heart. Slightly adjust the plane to get it parallel with septum and cut through the tricuspid valve. To acquire the RVOT view, right ventricular outflow tract, we can use 3-point localization method from 4-chamber view and shortest view. First point is placed in the tricuspid valve from the 4-chamber view. Second point is placed in the pulmonary artery, and second point is placed in the right atrium, both from the basal short axis view level. Not all the image planes are needed for each patient. It depends on what kind of heart disease of this patient was involved. In general, 2-chamber view, 3-chamber view, 4-chamber view, and short-surface view are needed for each CMR exam. If patient with left heart lesion, such hypertrophic cardiomyopathy, LV valve disease, and LVOT view must be acquired. If patient with right heart disease, such as TOF, ARVC, or Brugada syndrome, right heart, 2-chamber, and RVOT are needed. The last step of CMR is determine what kind of pulse sequence are useful to the patient. What can CMR offer? CMR can provide the myocardial structure and functional information in one-star exam. For myocardium, we can use turbospin echo to see the cardiac morphology, using the CMRI to assess the cardiac function and mass. For vascular tree, phase contrast scene is considered as gold standard to quantify the flow velocity in the great vessels. We can use the dynamic contrast enhanced MRI to quantify the microcirculation or tissue perfusion of myocardium. However, we have no time to acquire all of pulse sequence in one time. Therefore, we need to customize and give appropriate pulse sequence according to the different type of cardiac disease. Owing to the time constraint, I will only introduce 3 most common pulse sequence for CMR exam. For cardiac morphology, we can use dark blood preparation fast spin echo pulse sequence. Double inversion recovery is type of dark blood technique useful for visualizing the walls of cardiac chamber and blood vessels, including the coronary arteries. As the name implies, the sequence involves application of 2 RF inversion pulses in close succession after the ECG trigger. The first inverting pulse is specialized non-selective, and the second pulse is specially selective. After the 2 inversion pulses, tissue within the slice is unfaded, but the magnetization of blood outside the slice is inverted, so the blood will be black. This is dark blood turbospin imaging. We can see the ventricular blood is dark and highlight the cardiac lesion within the ventricular chamber. Triple IR is double IR sequence that including additional third slice selective inversion pulses shortly before the image acquisition. The third inverting pulses is used to null the signal from the fatty. Imaging on your left are examples of double IR and triple IR images at 1.5T, as shown here for comparison. The up imaging is double IR, the below imaging was triple IR. Can you find the left atrial myxoma? As shown here, we can see the triple IR is more significantly showing that. The figure showing here is the LV lipoma. The ventricular mass in the double IR imaging is bright and appears dark in the triple IR, which suggests the mass was composed by fatty tissue and considered as a lipoma. For ventricular function and mass, we can use steady-state free pre-section pulse sequence, as known as CMRI. The base pulse sequence is a bright blood technique, typically a balanced steady-state free pre-section SSP gradient echo method, such as TrueFISP. CMRI are typically obtained by repeatedly imaging the heart at a single slice location throughout the cardiac cycle. Sealing sequence use very short TE, about 1 to 2 milliseconds, allowing a multiple line of case space to be acquired within each frame during a single breath hold. Because only a limited number of case lines per frame are acquired, data must be collected over many cardiac cycles. A complete set of scene images for a given slice location can usually be collected in 5 to 10 seconds within a single breath hold. I think that is capable for most of patients. As shown here are the scene EMI in different imaging planes. We can use a myocardial edge detection algorithm to automatically segment the endocardial and epicardial contour. After obtaining this contour of LV, you can measure the volume change over the cardiac cycle, then calculate the ejection fraction, end-systolic volume, end-diastolic volume, and LV mass, and so on. We also can use scene EMI to measure the myocardial strain to assess the myocardial viability by using the feature tracking technique. Inversion recovery prepared TAIWAN pulse sequence with delayed contrast enhancement, also called late gadolinium enhancement MRI, can be used to identify the myocardial scar and assess the myocardial viability. The principle of LG is based on the gadolinium-based contrast agent do not enter intact myocardial cells, but distribute to the intracellular extracellular space of the myocardium within a few minutes after the contrast administration. We can see more contrast medium will accumulate in injury myocardium, such as acute myocardial infarction or myocardial scar. Due to the gadolinium accumulated, T1 value will shorten and result in a high signal on T1 weight imaging. We can see the contrast enhanced along the lateral wall of the LV at the site of infarction, as shown here. There are some important skills need to be mentioned. First one is breathing pattern. I would suggest using the inhalation and exhalation, then breath hold, to keep the diaphragm in a consistent position for each data acquisition. Second, acquire the data at the end-diastolic phase. You will have large chamber size and large cardiac motion due to the isovolume relaxation will occur in this moment. In summary, cardiac MRI is involving a rapid in both technical development and clinical applications. Therefore, regular fresh course and training sections are needed to update the knowledge and maintain the skill of CMI exam. Thank you for your attention.
Thank you, our second speaker. So next, our third speaker is Lin Yixian. She is also a radiographer at Department of Diagnostic Radiology, Xinguang Memorial Wuhuoshi Hospital. She is going to talk about initial experience of digital breast tomosynthesis, guided vacuum-assisted breast biopsies.
Hi everyone, my name is Lin Yixian. I work at the Department of Radiology Xinguang Hospital. Today, I'm gonna to share our experience about digital breast tomosynthesis guide vacuum-assisted breast biopsy. This is the outline. The introduction will talk about why breast biopsy is needed. I'm gonna to share our biopsy technique and the biopsy program. and analyze the advantage of digital mammography and the tomosynthesis biopsy. The last is conclusion. If there have a suspicious lesion in their breast, the breast biopsy may be recommended. The suspicious lesion can divide as a breast lump, calcification, or other sign and symptom of breast cancer. According to classification of instrument, biopsy can be roughly divided into 3 types: sonography guide, mammography guide, and the MRI guide. But some specific types of lesion, such as microcalcification, mammography guide biopsy are preferred. Mammography can divide into 2 different types of imaging modality: digital mammography and digital breast tomosynthesis. The challenge of digital mammography is that its accuracy may be limited only to breast tissue overlap, especially in Asian patients with dense granular parenchyma. Compared to digital mammography, digital breast tomosynthesis provides a series of low-dose mammograms at various angles through the breast, reducing the effect of tissue overlap. Just like Lick's animation, the circle represents the glandular, and the star represents the lesion. Because digital mammography is a 2D image, it is not easy to distinguish between the 2 tissues. But digital breast tomosynthesis can do it. Whatever it is microcalcification or non-calcified lesion, digital breast tomosynthesis has more advantage than digital mammography. Like Lick's image, breast distortion lesion can be seen here, but a digital mammography image is not obvious. Digital breast tomosynthesis is more suitable for breast cancer screening than digital mammogram. What about the biopsy? Is tomosynthesis as good than digital mammography? I will gonna show later. Next, introduce the equipment we use, including biopsy chair, mammotome, and the Giotto class DBT. The first is the biopsy chair. You can choose to sit or lateral decupit position for biopsy. Next, there is mammotome. Each sample is individually segregated into their own sample chamber. The last is Giotto tomosynthesis. When you want to check specimens, just take the chamber off and pull this out. Let it flat. And you stick in smart checker, take the specimen radiograph. You know where right away specimen had calcification. Biopsy program, there are 5 steps, including targeting, retargeting, tissue collection, check specimen, and the liver marker. First step, digital mammography targeting technique requires 3 separate sets of 2D mammogram image, 0 degree, plus and minus 15 degree. and the triangulation is required to determine the depth of the target. On the other hand, digital breast tomosynthesis only require one set of 3D projection and have the depth information at the same time. For this case, the distortion breast lesion is about 38 mm away from the detector. But in the case of a digital mammography, only calcification can be seen, and the depth cannot be seen. Step 2. Retargeting. Prefer exposure to confirm needle position. Digital mammography targeting using two sets of plus and minus 15-degree mammography image. Because the image at 0 degree will be blocked by the needle. Digital breast tomosynthesis is a special because the needle tip is close to the breast. There will be a metal artifact after tomosynthesis recognition, but it will not affect the target. Step 3. Tissue collection. This step didn't necessarily require image, because the lesion will be blocked by the needle tip. In fact, we couldn't see the calcification where it is. After tissue collection, check specimen had calcification. Without decompression, gel-toe tomosynthesis is a simple but extremely efficient tool to extract tissue sample within a few seconds by using the uncovered active area of the detector. But digital mammography didn't have this function, so the specimen can only rely on other instruments during digital mammography biopsy. Not only need to spend a sum of equipment expensive, but also need to empty a space for the instrument. If none of calcification were present in the specimens, then it's necessary to continue to collect specimens. Final step. Leave a marker in the breast. Whatever digital mammography or tomosynthesis, using one set of plus and minus 15-degree mammography image to make sure mark no failure. We collect 200 biopsy cases for digital mammography and tomosynthesis respectively, from January 2020 to June 2022. Compared with digital mammography, the execution time for digital breast tomosynthesis biopsy less 20% than digital mammography biopsy. Even if there are more than 12 specimens, just like this picture, more than 12 specimens, the overtime is shorter than that of digital mammography. The advantage is to reduce biopsy time, could save compression time and the investment for additional scanner. Reducing biopsy time had 2 points. One is digital breast tomosynthesis scan faster than digital mammography. The other is Smart Checker quickly check specimen at the end of a procedure. The disadvantage is that the reconstruction time will increase when compressed breast thickening increased. I didn't record biopsy exposure this time, but many literature indicate that digital breast tomosynthesis is less exposure than digital mammogram. Look at the list table. The digital mammography means of exposure is 12 times, and the digital breast tomosynthesis biopsy just 3 times. So, tomosynthesis not only reducing biopsy time, but also reducing radiation dose. In conclusion, digital breast tomosynthesis guide biopsy are efficient and easy to perform, and reduce significantly overall procedure time. In addition, more architecture, distortion, and asymmetry are enabled to biopsy when digital breast tomosynthesis guide vacuum assist breast biopsy. This is the end of my presentation. Thank you for your listening.
And thanks for our excellent speakers. We hope that the viewers of today's talk can gain great insight from their wealth of knowledge in professional field. So next, we're gonna move to Q&A session. So there is some question for Mr. Yu Changqing. Yeah. And the question from Indonesia, the question is, what are the potential risks associated with the use of 20-minute Curie 99 TC-MDP in whole body bone scans?
Mr. Chang, your mic is off muted. Kindly switch on your mic. Mr. Chang.
Mr. Yu Changqing.
Please open your microphone. Thank you.
I'm sorry. Okay, I had to explain the question. Yeah. So I think that the potential risk is the contamination in TC99 MDP bone scan. You know, sometimes the patients have the urine or injection site or contamination have the on their body or their injection site will over to bother the truly bone scan image. So at first, we have to make sure patient have clean their contamination or their urine has is clear. Then we will to make sure this potential risk.
Okay, thank you. So next, the second question is also for Yu Changqing, and so is the also called image segmentation using IFV? And if so, is the architecture like CNN or UNet? I think is the number of databases using sufficient to avoid overfitting?
Okay, this is a good question, but we use the IFV is not the segmentation. We just at first would have to try to perform non-supervision type of neural network training to find the gradient and the kinetic energy of the index value. So bone scan image, we have to separate 3 types of the patients. And second time, we will move to the second stage is to use the view tool, just like the abnormal flow browser for assessing the abnormal flow point of the Gaussian analysis to correct the image histogram in order to obtain cell cluster or union cluster index according to the correction distance from the central to discrete abnormal flow of cumulate points has found. So it is not an image segmentation. We use the original image to find the IFB. We can use the IFB inference to make sure where is the normal or metastasis.
Yeah, okay, thank you. So Mr. Yu Changqing, I do have a question for you. So you mentioned that there are 106 patients receive a dose of 20 curies, right? And I'm just wondering, what is the range of dose received by patients of different sizes?
Okay, this is a good question. For the general or usual adult dosage is almost 20 millicurie investigated. But for the overweight, the dosage is up to 25 or 30 millicurie. But for the dosage pediatric patients is about 250 or 350 millicurie per kilogram. The lowest dosage is 1 millicurie. So the maximum dosage should not exceed the adult dosage. This is my answer.
Okay, thank you. Good to know. Yeah. And so thank you, Mr. Yu Changqing. There is a question for Mr. Su Maoyuan. So the question is that the perfusion is essential for cardiac tumor, and for myocardial infarct, zinc can be effective, and for all indications, are chamber views enough for interpretation?
Yes, perfusion should be useful for cardiac tumor to know the vascularity of the tumor. However, in my experience, the post-contrast dark blood T1 or T2 wave imaging is enough to see the enhancement of the tumor region. So I think maybe you don't need to use the perfusion. You just acquired post-contrast and dark blood T1 or T2 wave imaging, and you can see if the tumor will enhancement. That would be knowing the vascularity of this mass. The second question about the myocardial infarct, CNE can be effective. As we know, a CNE-MI can see the myocardial contractility. So if the myocardium has ischemia, not infarct, so we can see the wall motion may be low, even how can I say? Because if the myocardium was ischemia, it will hibernating to for the rescue. So if you see the CNE-MI, you see the myocardium wall motion is low, but there is no hyperenhancement on LGE, which means the myocardium is ischemia. If you see the myocardium is less contractility and LGE also enhancement, that would be sure the myocardium is infarct. For all indications, chamber view are enough for interpretations. As I mentioned, 2-chamber view, 3-chamber view, 4-chamber view, and shortest view are needed for all cases. However, we also need to know what indication of this patient for CMR. For example, if this patient is right heart problem, So we need to acquire rights such as RBOT or right side to chamber view. Because we need to shorten the examination time within the 1 hour. So we don't need to acquire too much view for this patient. So I think it depends on what kind of cardiac disease of this case. But as I say, 2-chamber view, 3-chamber view, 4-chamber view, and short survey are needed for all cases. I don't know if I answer your question at all.
Okay,
thank you, Professor.
Okay, so thank you. So is there any questions from our panelists?
Okay, I have a question. Sorry, I have a question. You hear me? You hear me?
Yes.
Okay. Mr. Chan have a question. Mr. Mao also have a question. I have one question for Mr. Ling. Mr. Ling, biopsy from Mr. Ling. Mr. Ling, in the third speaker, why you in your presentation in biopsy in memory digital memo, I think okay, but maybe only for in calcification, very small calcification. But I think within tumor, small tumor, maybe we biopsy by ultrasound may be better, very easy. How about in your country? You understand me? We have biopsy only for calcification. You showed almost the calcification. You okay? But I think if not calcification have a small tumor, you can biopsy a guy by ultrasound may be better. How about you?
Means
you biopsy calcification. Most calcification, okay? Most small calcification.
No,
okay.
We don't use the we use we have to see the microcalcification only use the mammography or tomosynthesis. Not use the we don't use the sonogram because the because the is it is hard to find the classification in the sonogram. So we have, if the men have a macro classification, we just use the mammography or tomosynthesis.
Sure, correct. Yeah, correct. I confirm, correct. It micro calcification. We use digital mammography. Okay, very good. Make sure. And if a tumor and with small tumor, maybe we use in guide by ultrasound may be better. Very easy. Very easy. Correct. Okay, thank you.
Okay, thank you.
Thank you. Thank you.
So I would like to once again thank our three speakers for today's informative presentations and thank all of you for your contribution. So I think I might hand back to Ms. Peachy. Thank you.
Yes, thank you, Alice Chang, for that smooth moderation. And thank you very much to our presidents and to our panelists. The Taiwan Association of Medical Radiation Technologists, TAIWAN, has just provided us the three great speakers who have just shared to us very interesting discussions. Thank you so much to our distinguished speakers, Mr. Chang Ching Yu, Mr. Mao Yuan Su, and Ms. Yi Xian Lin. We have learned so much from your interesting and important discussions. But in the interest of time, we have to cut from here to give way for the closing session. And as I know, we are all excited to know about the details of the next exciting online CPD Asia schedule, and to address to us an invitation and to tell us more about this exciting event, let us all welcome President Selva Kumar of the Indian Society of Radiographers and Technologists, ISRT.
Namaste, and thank you all for the support. And we are very delighted to be on board with the Asia CPD programs. For the past 2 years, we are part of the things. And first time we are planning to host Asia CPD from India, Indian Society of Radiographers and Technologists. Before my making announcement, I will congratulate all the 3 speakers today from the TAIWAN Association. They made a very interesting one, really data-oriented. Lot we can able to got information, and we can utilize in our studies or in the research works in India also. Thank you. And once again, I congratulate the new Macau Radiographers Association panel of members newly elected, Mr. Fernando Kak as a president, and Ms. Scora NG as a chairperson. I congratulate the team for their thing, and we are always be part of the team, and we are ready to be associated with you all, madam. Thank you.
Thank you.
And for Asia CPD, we are planning to host on March 19th. It's coming on Sunday, and we are coming with 3 interesting topics, likely on CT, and 3 energetic new academic persons are going to present the papers. There are 2 female and 1 male person from the academic. As a first program, we are going to start with academic persons. So hope that program will be interesting to all. And soon we will give you the flyer with the details or timings and other things. Thank you all for the joining with the programs, and we are welcoming you all members to be take active participation as usual in our programs, and hope it will be a very interesting one. Thank you.
Well, thank you, President Selva Kumar of the ISRT. We'll surely mark the date, March 19, 2023. So again, congratulations to the Taiwan Association of Medical Radiation Technologists, TAMRT, President Chun Yuan-tu, to all your officers, the organizing committee of the 22nd CPD Asia. We give thanks also to the support of our many sponsors, including VT Healthcare Vietnam. Also, we are grateful to our 3 great speakers, and most of all, we are sincerely grateful to all the member societies presidents, and to our hardworking CPD Asia team, and to all the registered participants who have made this online CPD Asia program successful one. So see you again in the next Asia CPD. Again, I am Peachy Luna, and I say thank you, everyone. Have a great day.
Thank you, Peachy.
Thank you.
Thank you.
Thank you. Thank you.
Next time.
Yes.
Thank you.
See you again.
Yeah.
Bye-bye.
India remember multi-thousand audience look forward in March.
Yes, India is the first time to join us.
Yes.
We'll give our full support to their first
Thank you.
hosting
Bye-bye.
of the CPD
Yes.
Asia.
Thank you. Thank you so much.
Looking forward. Thank you.
Thank
Bye-bye.
you.
Bye.
Hello, thank you.
Thank you, sir.
Hello.
Yes,
so
sir.
far?
How are you, sir? Very fine. Thank you. Happy to see you.
Yeah.
Mm.
Very good. Yeah. I am on the way to Jogja right now.
Okay.
Yeah.
That's
Okay.
why I
Yeah.
see you with a
Okay.
different suit.
Thank you,
Okay,
sir.
sir. Have a nice time. Thank you all.
Yeah. You
Thank
too.
you,
You
sir.
too.
See you,
Okay.
sir. Happy weekend to all.
Safe trip Bapak Ketum.
Ya, Mas. Oke, Mas.
Ya, terima kasih. Sorry.